Welcome to The Explainer. Listen, today we're talking about a condition you're absolutely going to see in your practice. It's one that's often missed, often misdiagnosed, and it can be totally debilitating for patients. I'm talking about Postural Orthostatic Tachycardia syndrome, or as we all know it, POTS.
All right, let's just dive right in with a classic scenario. Imagine this. A patient, usually a younger woman, walks into your clinic. She tells you she's dealing with this chronic lightheadedness, her heart feels like it's racing, and she's just exhausted. But here's the kicker. It only happens when she's standing up. Right away, that should scream orthostatic intolerance, and POTS has got to be right at the top of your differential.
Okay, so if we're going to nail this diagnosis, we have to be super clear on what POTS is, and just as importantly, what it's not. Okay, here's the absolute heart of the diagnosis. It all comes down to that huge, sustained jump in heart rate. We're talking 30 beats per minute or more within 10 minutes of standing. But, and this is the really critical part, this happens without that big drop in blood pressure. That's what separates it from good old-fashioned orthostatic hypotension. And this table here is just fantastic because it lays out the mimics side by side. So let's look at the main hemodynamic change, right? For POTS, it's all about that excessive tachycardia. For orthostatic hypotension, it's a sustained drop in blood pressure. And for vasovagal syncope, that's more of a quick, transient episode of both bradycardia and hypotension. You've got to know these differences. It's totally essential for your workup.
So who gets POTS? Well, take a look at this. It really paints a picture of your typical patient. It's overwhelmingly young women. I mean, a 5-to-1 ratio, that's huge. And symptom onset is usually between 15 and 50. So you can see how this condition really hits people right in what should be the prime of their lives.
All right, so now let's get into the why. Why does this happen? Understanding the pathophysiology is so key because it helps us make sense of all the weird, multi-system symptoms our patients have. And believe me, it is not just one single thing gone wrong. So to get what goes wrong in POTS, you first have to appreciate what goes right for the rest of us. It's actually amazing. When you stand up, a whole pint of blood rushes to your legs. Instantly, your autonomic nervous system kicks in, squeezes your blood vessels, and keeps blood flowing to your brain. But in POTS, well, that system goes completely haywire. The end result is the heart just freaking out, racing like crazy, trying desperately to push blood back up to the brain. One of the big theories here is this really nasty, vicious cycle. It starts with low blood volume and maybe some deconditioning. The symptoms make standing up feel awful, right? So what do? You avoid it. You become less active. That leads to more deconditioning, which just makes the tachycardia even worse when you do stand up. It's a feedback loop from hell, and it's incredibly tough for patients to break out of on their own. Okay, for another group of patients, it's all about a hyperactive sympathetic nervous system. You can think of it like their fight or flight response is just stuck in the on position, 24/7. Their body is constantly flooded with catecholamines, either from too much release or because it's not being cleared properly. It puts their whole system on this constant state of high alert. And then there's neuropathy. In fact, for up to half of all POTS patients, the root cause might be a small fiber neuropathy. We're talking about the tiny, tiny nerve endings that control all the automatic stuff, like telling your blood vessels to squeeze or telling you to sweat. When those are damaged, the whole system just goes haywire. And this doesn't just explain the lightheadedness, it's often why they have so many GI issues too. Finally, there's a huge growing body of evidence for an autoimmune cause. It is so common to hear a patient say, this all started after I had a bad virus. And lately, of course, we're seeing a ton of this post-COVID. The idea is that the immune system gets confused, it goes rogue, and starts making antibodies that attack the body's own autonomic system. It's a really active area of research. Okay, so we've got all this complex pathophysiology swirling around. How do we take that and actually make a diagnosis in the clinic? What's the pathway? When it comes down to it, the diagnosis hinges on this one single number, plus 30 beats per minute. Or, if your patient is under 20, plus 40. That sustained increase within 10 minutes of standing is the objective black and white finding you're hunting for when you do a simple set of orthostatic vitals. So the workflow is pretty logical. Step 1, you take a really good history and you do that standing test, right there in your office. Step 2, if you need more confirmation, is formal autonomic testing, like a tilt table test. That gives you super objective evidence. And step 3, of course, is you run the basic labs, CBC, electrolytes, TSH, to make sure you're not missing something else that could be causing these symptoms. And please remember, the symptoms are so much more than just a fast heart rate.
This is a multi-system mess. You have to listen for the other stuff, the bone-crushing fatigue, that awful brain fog they talk about, and this classic coat hanger headache, pain in the neck and shoulders. Oh, and here's a pearl. Ask them if a hot shower makes it all worse. The vasodilation from the heat is a huge trigger. They'll almost always say yes.
Okay, so you've got the diagnosis. Now what? The focus totally shifts to management. And the good news is there's a really clear step-by-step approach, and it always starts with non-drug therapies. Look, the absolute foundation of treatment is not a pill. I can't stress this enough. Before you even think about writing a script, this is where you have to focus. We're talking aggressive fluid and salt intake to boost their volume. A very specific, gradual exercise program, often starting with them lying down like rowing or swimming, and then compression gear. Patient education on this stuff is everything.
Now, for the patients who are still really struggling after trying all of that, that's when we move to Tier 2 and bring in medications. And the choice of drug really depends on what you think is going on. Is it a hyperadrenergic state? Try a low-dose beta blocker. Do they need more vasoconstriction to fight that venous pulling? Midodrine is your go-to. Need to boost volume even more? Fludrocortisone can help with that.
So, last but not least, what do you tell your patients about the future? What's the prognosis? And really, why does this all matter so much? The good news is the long-term outlook for feeling better is pretty good. Most patients do improve with treatment. But, and this is a big but, you have to set expectations. This isn't usually something that just goes away. For a lot of people, POTS is a chronic condition that they'll have to manage for the long haul, with good spells and bad spells. And I want to leave you with this, because if you take nothing else away from this, please take this. This quote says that the functional limitations, what patients can and can't do in their daily lives, are comparable to people with COPD or congestive heart failure. Just let that sink in for a second. We're talking major organ failure level disability. So this is not just anxiety, it is not all in their head. This is a serious, debilitating condition. And it's on us to see it, to believe our patients, and to give them the care they so desperately need and deserve.